Hello, this is Dr. Amin Marashi, retina specialist from Aleppo, Syria. This course is about clinical changes in RPE. This presentation is about case report series, part 1. A 66-year-old lady, pseudophakic, presented with features of AMD. Her best-corrected visual acuity is 20/200 in her right eye, while her left eye, the best-corrected visual acuity is 20/35. Fundus examination showed drusen and signs of dry AMD. Fundus exam shows heterogeneous sub-RPE drusenoid forming transforming drusen, soft drusen, RPE atrophy, and adjacent to it there is a small intraretinal cyst. OCT scan shows areas of RPE atrophy, which features absence of RPE layer with pronounced Bruch's membrane, and the light is not reflected and passes through the choroid, increasing its reflectivity adjacent to heterogeneous sub-RPE deposits, forming transforming drusen, along with the presence of hard drusen and disturbance of ellipsoid zone with normal central retinal thickness. Another finding of radial OCT cross-section is an intraretinal cyst next to RPE atrophy and ellipsoid zone disturbance, with no increase of central retinal thickness. Fluorescein angiogram shows transforming drusen that feature heterogeneous hyperfluorescence in the early phase that is more pronounced in mid-phase, along with hyperfluorescence from the intraretinal cyst and hyperfluorescence from window defect due to RPE atrophy. However, in the late stage, the transforming drusen is causing heterogeneous staining, along with leakage from intraretinal cyst and homogeneous staining from the soft drusen, along with fading of hyperfluorescence in the area of RPE atrophy without changing its border or leak. The FFA does not show any signs of choroidal neovascularization. The diagnosis is transforming drusen in the setting of dry AMD. Management is close follow-up with oral supplements. Transforming drusen is a heterogeneous sub-RPE deposits, which usually a sign of hard drusen becoming soft drusen. It varies in size, and usually it is a prognostic factor of developing choroidal neovascularization or atrophy, as in this case, where the ellipsoid zone is disturbed, causing reduction of vision with marked RPE atrophy. The intraretinal cyst, which located in the inner nuclear layer, is not causing macular edema, with the lack of the presence of RPE detachment or subretinal fluids, which are signs of wet AMD. Intraretinal cysts can be unique at this case or multiple, and usually they are associated with geographic atrophy as a result of molar cell degeneration or loss in intermediate stage of the atrophic process. It is essential to differentiate intraretinal cysts in advanced AMD from outer retinal tubulation, which presents in spectral domain OCT as a circular or focal structure in outer retinal layers with hyperreflective borders, contains hyperreflective material. Wet AMD or retinal angiomatous proliferation can differentiate from intraretinal cystic changes as the former may cause in retinal thickness and subretinal fluids with or without pigment epithelial detachment, with the presence of leak on fluorescein angiogram from choroidal neovascular membrane. A take-home message: when transforming drusen diagnosed, a close follow-up is warranted, and this type of drusen may be a prognostic factor for developing choroidal neovascular membrane or RPE atrophy. Hence, patient education is essential, as intraretinal cysts without causing cystoid macular edema in the setting of advanced AMD should be interrupted with caution, especially in the absence of fibrovascular pigment epithelial detachment and leak from choroidal neovascular membrane based on fluorescein angiogram. Choroidal neovascular membrane can be ruled out using ICG or OCT angiography because those cysts do not warrant any treatment in the absence of choroidal neovascular membrane. Please stay tuned for my next presentation about Case Report Series Part 2, which I will discuss cases of PAD in wet AMD. I hope you find this information are beneficial in your clinical practice. Thank you for listening.